Well, howdy, everyone. I'm David Glazer. I'm here with a whole bunch of colleagues.
Hi, I'm Katie Olson.
This is Catherine Linden.
Marguerite Amen.
Pari Magera.
So we are going to walk through a whole bunch of stuff today. I'm not sure exactly how long this is going to go. When we set it up for an hour and a half. That's because I mistakenly believed, I was certain that the bundling for the cardiac bundling final rule would be out. It seemed like a safe bet because it was at the CJR rule came out with a quicker turnaround, and this is their second pass at a similar topic. So I was quite confident it would be out by now. It is not. So that is not on our agenda anymore. But we'll talk you through a bit of MIPS at the 30,000-foot level, the physician fee schedule, outpatient rule, and some other breaking news. Just a small number of announcements. First, I guess the reason we thought it was November 14th is this is the beginning of our 11th year of doing webinars, which freaks me out a little. So 11 years into this. Remember, our past webinars, not all 11 years worth, but like the last 3 or 4 years, you can get on the web at our website. If you have a hard time finding it, shoot any one of us an email, and we'll send you the link. I believe that the January 11th webinar is going to be by 2 of our immigration colleagues, Bob Aronson and Deb Schneider. Not 100% sure, but that is most likely. You'll get a confirmation email in the next few days. February is most likely a HIPAA update, but we'll see. If sound goes to heck in a handbasket, and it periodically does over the noon hour, you can always dial in and use that. If you want to ask us questions, you can always email any one of us. But during the webinar, the mechanism to use is if you go over the bottom of the screen and hover, a little box pops up, and you can type your question in there. So we're going to start off with some news. Then we'll do the physician fee schedule, a little bit about the clinical lab fee schedule, the inpatient prospective payment rule, the outpatient prospective payment rule, a little bit about the MIPS quality payment program, and then end last but and least, I would say, definitely least, with the OIG work plan. So the news. Some of you may have heard a very interesting case last week. So the American Hospital Association sued Secretary Burwell to complain about the backlog at the ALJ level.
Which, just to put things in perspective, is like 900,000 cases that are sitting there waiting to be heard.
And to put it in another way, it's like 7 years.
Yeah.
I mean, it's a crazy backlog. It makes us look quick, right? And so
If there's any consolation.
Right.
So the lawsuit, it's been going on for a while, and courts are generally very reluctant to rule against the government, and they're very particularly reluctant to tell the government what to do. This was a lawsuit. It's called you're seeking mandamus, which is basically an order to make the government do something. And originally, they said to the government, hey, you got to come up with a plan. Show us your plan to fix things. Well, they didn't really come up with the plan very well, and so now the most recent order, the plaintiffs requested that various things be done. Maybe the 68% solution be the 68% settlement be offered to all hospitals. A variety of things were considered in the litigation, but what the court decided to do is to say, we don't care how you do it, CMS, but by December 31st of 2017, 30% of the backlog has to be gone. A year after that, 60% has to be gone. A year after that, 90% has to be gone. And then by the end of 2020, no backlog. And we don't care how you do it. The order doesn't say what happens if CMS fails. There was a request that there would be default judgment enters, which basically means you automatically win if they don't meet that. And CMS said, we don't like that because it creates a strong incentive for a whole bunch of people to file frivolous appeals right now. And the court said they wouldn't, at this stage, say that everyone will get a default judgment. That could happen. And I think from a practical level right now, if you've got a case to appeal, there will be a backlog, but that shouldn't stop you from, I personally am principled enough that I wouldn't say appeal a crappy case. But if you got a good case, you shouldn't let the backlog deter you. You appeal. Katie, I know you've been dealing with a lot of this stuff. You got anything to chime in on?
It just will be interesting to see if they can actually churn out the decisions. 30% is many decisions considering they don't have very many judges. So
yeah,
they might not be good decisions, and that's the scary part.
We've definitely noticed, would it be a downtick in the quality of the decisions? I feel like that the last few decisions we've seen have occasionally had been just sloppy. Like just stated the issue of the case incorrectly.
Right, right.
So, all right. The next one is an interesting one. A national publication caught my eye when it said a new rule limits, I think it said, providers' ability to pay the exchange premium for patients. And that's a big deal because we've written a memo for a bunch of high-profile clients saying, hey, you can pay the premium for an exchange patient. That was somewhat controversial, but I think it's crystal clear you can do it. So I saw this headline and thought, oh my gosh, my advice is wrong. Better fix that. Then I got the rule. And the rule does not say exactly that. The rule only applies to end-stage renal disease facilities. And actually, that I wouldn't have even put this in, except that I saw the newspaper articles making it sound like a different rule. And so really this is here for 2 points. One, just to remind people, if you're a hospital or a clinic for that matter, and you want to pay the exchange premium for someone, you can, I think. And you can, if you want to get more details on that, shoot us a note. And remember when you read articles, especially about complicated rules, they get it wrong sometimes, because this one did. All right, next, Katie and I are going to give a little bit of thought about what the heck is up with health reform. And I often use research materials to figure this out. And one of my favorite is the Magic 8 Ball. And I've consulted the Magic 8 Ball, and it has not been a ton of help.
Everybody's going to ask for their money back, David.
And we will give it. I don't know. Katie, what do you think is going to happen with health reform?
That's an unfair question. I saw a good analysis by the New York Times of why you couldn't get rid of one piece without it affecting the other, in terms of the individual mandate and the exchanges and the pre-existing conditions. And it was pretty nonpartisan and pretty simplified overview, 10,000-foot view, and I'm happy to send it to whoever would like to see it because I thought it put things in perspective.
And so your email is in the back.
Yep.
The last slide has all of our email and contact information, and people can drop you a line.
What's been interesting to me, sort of maybe from the, I guess, lawyer perspective, is what if the whole statute went away, what else goes away besides kind of the big three, the mandate, the exchanges, the pre-existing conditions?
Well,
and there's just a lot of other stuff there, too.
60-day rule, obviously,
60-day
is one
rule.
thing that's in there. What
Yep.
else we got? I can think
A lot of people right now are scrambling to comply with the Section 1557 regulations, anti-discrimination regulations. That was part of the ACA. Compliance plan, mandatory compliance plans for SNFs. ACOs, Medicare Shared Savings Program.
I think there were a couple of
Value-based purchasing program.
some safe harbors.
Safe harbors. There were a couple exceptions to the CMP rule. The one that we grappled with right around 2009 was, or I'm sorry, 2011 was the technical notice of other imaging providers.
Oh, yeah.
If you are trying to comply with the in-office ancillary services exception to Stark. So that was also part of the ACA, which I had forgotten about.
I would have not thought of that as part of the ACA. And so now we could go through the whole list. One of the challenges here is we don't know what's going to happen.
Right. Right.
And are there other biggies?
Well, all of those screening requirements, new screening requirements, background checks, fingerprinting, all of those programs were part of the ACA. The concept that if there's a kickback underlying a claim, it's automatically a false claim. That was an ACA piece. So, I mean, there are self-referral disclosure protocol.
Yep.
There's a whole industry on that.
So now my gut, if I were betting, there's no way it all goes away.
No.
Because people will figure this out. And, you know, it's interesting. I've often heard physicians say, oh, we're going to have a Republican administration and they won't go after health fraud. Well, let's just say I don't feel like I was materially less busy during the Bush administration than during the Clinton or Obama administrations. I think health fraud is bipartisan. Everyone loves to crack down on it. And I think almost none of the stuff, you know, I would bet good money the 60-day rule is not going away. They will figure out a way to keep that in, is my strong hunch. Now, the reply is hazy, try again. There are a couple other, you know, and I saw another article that talked about how Tom Price wants to get rid of the antitrust laws as it applies to physicians that would permit physicians to jointly negotiate with insurance companies. That could be great for physicians. Remember, Tom Price doesn't have the ability to do that by fiat. It would require something happening in Congress, and I wouldn't take that to the bank. So we'll watch a lot of this stuff. but I think expectation of change is often that we don't live up to it. So that's our magic 8 ball. Let's deal into some things that actually happen. I think we're going to start with Catherine London, who's going to walk us through one of the I guess less stark-oriented. You know, sometimes there's really funky stuff in the physician fee schedule. I think it's a little less funky, but there are some interesting tidbits floating around in there.
That is true. And as Marguerite will talk about a little bit later, there was a sort of a non-stark update that was included in the fee schedule. But I get to kick off our discussion about the 2017 fee schedule, which was released on November 2nd. And I always like to mention that this is one of the hardest webinars we do because the fee schedule will cover so much ground in terms of changes to CMS policies. And a lot of these changes are important only to a really limited audience, so we do our best to highlight as many of the changes as possible that might be of interest to folks who are on this webinar. The first topic I'm going to cover is a new data collection initiative by CMS. And under the Medicare Access and CHIP Reauthorization Act, MACRA, CMS is required to begin collecting data regarding surgical services that are paid as part of global packages. And in the proposed fee schedule that was released last July, CMS had presented an initial proposal for this data collection process that applied to all practitioners who are providing 10 or 90-day global services and would require practitioners to report data to CMS using a series of new G codes. In response to that proposal, CMS received a lot of pushback and really got a lot of feedback and comments about the administrative burden this would impose on practitioners. So in the final rule, CMS significantly revised its approach and scaled back the scope of the initial phases of this data collection process in an attempt to minimize this burden. And under the final proposal that was released, CMS is requiring reporting only for practitioners in large practices, which is defined as a practice with 10 or more practitioners, and who are located in one of the 9 states that's identified on this slide. And CMS expressed that reporting will be voluntary for all other providers. So obviously this is a very different data collection process than was initially proposed. Under the final proposal, practitioners are also going to be required to report only for post-operative visits. Reporting will not be required for any pre-operative visits that are included in the global package. And this is in part due to the fact that CMS also decided not to use G codes for this type of reporting, but will instead require reporting through the use of an existing CPT code. And CMS had noted that this code provides data only on the number of visits and not the level or resources that are used in providing the services. So for this reason, CMS considers this to be just the initial, just the first step in this data collection process as they try to comply with the statutory obligations under MACRA.
So, Catherine, I mean, I guess, you know, obviously if you're not in one of those 9 states, you can sort of, you may have zoned out for a moment here because you don't have to worry about this. But presumably this is kind of an indication of stuff that might be coming down the pike. They're gathering this data for a reason, and there may be change on the horizon.
That is correct. And their statutory obligation is quite broad, and they're trying to get around it for the initial phases because of how burdensome their initial approach was. But they did express at least a couple times in their comments to the final rule that there's more to come. Reporting will apply for services that are related to global procedures furnished on or after July 1st, again, rather than January 1st of 2017 as initially proposed. And CMS indicated that it is also going to require participation in a survey for selected practitioners in mid-2017 as an additional effort to gain information on the post-operative activities.
And this is probably stating the obvious, but I think what's going on here is CMS is worried they're overpaying, that basically there are fewer encounters happening during the global period than they think is currently set up, and so they want to whack it.
That is correct. MACRA requires CMS to find out more about the valuation for the services that are actually being provided and the level of services, the nature of the services. And so they're doing what they can to figure out what what they will be paying in the future for those types of services. I am going to move on to discuss certain changes that were also included in the final rule regarding Medicare Advantage provider enrollment requirements. Under current regulations, Medicare Advantage organizations are required to have screening procedures that are in place for their contracted providers and suppliers. As part of the final fee schedule rule, CMS finalized a proposal to revise these regulations and require that any providers and suppliers must be enrolled in Medicare and in an approved status in order to contract with Medicare Advantage organizations to provide services to Medicare beneficiaries. CMS has stated that this change is intended to create consistency with other parts of Medicare. And under the final rule, Medicare Advantage organizations are prohibited from paying any individuals or entities that are excluded by the OIG or have their participation revoked by Medicare. And this is regardless of whether that practitioner or that individual or entity is in an in-network or out-of-network status with the Medicare Advantage plan. These new enrollment requirements will be included in all CMS contracts with Medicare Advantage plans, and plans will be required to maintain documentation demonstrating their compliance with these requirements and showing that all of their contracted providers and suppliers are actively enrolled in Medicare and in an approved status. So in terms of enforcement, CMS has expressed that any non-compliance could result in sanctions that include contract termination. And CMS said in the final rule that it's going to use its discretion to determine the appropriate action to take if a plan is not complying with these new requirements. These will go into effect in 2019, and the enrollment requirements will be effective on the first day of the plan year. Shifting gears a little bit, I wanted to do at least a brief overview. This is a very high level of changes that CMS included in the final rule regarding the Medicare Shared Savings Program. And so I should mention that there were quite a few changes, and a lot of them are very technical, so we're providing kind of a high-level overview here of some of the key revisions. First, there are a number of updates to the ACO quality reporting requirements, which include changes to the quality measures that ACOs are required to report, and these are reduced from 34 measures to 31 measures under the final rule. There were also a number of updates to the procedures for quality validation audits that are performed by CMS, as well as new policy allowing eligible professionals and ACOs to report their quality separately from the ACO, which is a change to the current procedures.
Catherine, I'm just going to interrupt for a second because there's always a confusing lingo thing here, which is CMS opted to use Medicare Shared Savings Program to describe the ACO program. They also, about 2 years before they did that, used it to describe a proposed rule applying to what often is called a gain sharing or co-management deal. And so I just want to mention, if you're hearing shared savings and you're thinking, I thought shared savings applied when a hospital shared savings with a physician in the hospital context. That term can be used there too. It's just CMS's attempt to mess with our heads. Okay.
That's a good point, and that term certainly makes sense in that context. So there were also updates that were intended to align the ACO reporting requirements with the PQRS and quality payment program requirements, which we are planning to touch on a little bit later in this webinar. And then finally, as part of the final rule, CMS is making changes to the beneficiary assignment algorithm to allow beneficiaries to designate an ACO professional as the individual they consider to be responsible for their care. And this is a voluntary option, and beneficiaries will be assigned to an ACO using their current claims-based process if the beneficiary does not elect to use this option. Switching gears again, I want to talk a little bit about the telehealth changes that CMS included in the fee schedule final rule as well. CMS continues to seek input and add new CPT codes to the list of services that are covered if they are provided by telehealth. And for 2017, CMS has decided to add the codes I've identified on this slide relating to ESRD-related services, advanced care planning, and also telehealth consultations for patients requiring critical care services. Should mention in general that the expansion of telehealth for Medicare continues to be very slow, and this is in part due to the fact that Medicare remains pretty constrained by their statutory restrictions on what can and cannot be furnished by telehealth, so it's always not that much of an exciting update for the telehealth services that are covered. However, CMS did finalize a new place of service code that will be used for telehealth services, and this was in response to a lot of confusion among practitioners about whether to use the place of service code for the location of the patient or where the distant site practitioner was located when providing services by telehealth. And in the past, CMS has instructed practitioners to report the code that would have been reported if the services had been furnished in person. However, a lot of providers requested a specific code to be used for telehealth purposes, so CMS has finalized this new approach and also clarified that this code would not apply to any originating sites, which is where the patient is located, who are also billing a facility fee. And distant site practitioners who are providing telehealth services will be using this code and will be paid the facility practice expense RVU, regardless of what their actual location is.
So I'm going to ask Ms. Ilton a question here, which is because this place of service stuff comes up all the time, and I am curious. What do you think if you screw it up? Right, you've discovered you've blown the place of service. Do you have to refund?
So I think that you would ask yourself, first of all, is there a payment differential between the place of service that you used and the place of service you should have used? And if there's not, then you arguably are not overpaid. I suppose someone could say that it's a false claim if you use the wrong place of service, but I think in order for it to be a false claim that requires a refund, that place of service would have to be material to the government's payment, and if there's no payment differential, then it doesn't seem very material to me.
Yeah, and so I think that there are situations, and we just mentioned this because this comes up a lot, and it is worth talking about them when they arise, but I guess what I'd say is if you have this situation, don't panic, give us a call, and the odds are we're going to tell you you're not going to have to refund. You might have to fix your claims.
Yep,
that's a whole other ball game. But it's just worth mentioning because I know we've struggled with place of service since I was a baby lawyer, and they keep changing. So back to the cool stuff from Kath.
That's a good point. So this new place of service code will be used for any services that are provided by telehealth on or after January 1st of next year. And the last topics I'm going to touch on before handing it off to Marguerite are a few topics related to coding changes for certain Medicare services. And the first relates to moderate sedation. And this change is in response to CMS's realization that practice patterns for endoscopic procedures were changing. And anesthesia was being increasingly reported separately, meaning that the resources associated with sedation were no longer incurred in many cases by the practitioner who had been reporting the procedure. So in other words, CMS was concerned that these procedures that included moderate sedation as part of the inherent part of the procedure were actually being overvalued. And in response, CMS has finalized new values for CPT codes to be used when moderate sedation services are separately performed. And in connection with this, CMS also finalized downward adjustments for RVUs for procedures that included moderate sedation as part of the procedure. I also wanted to mention there's a new coding framework that was established for Mammography Services, and these changes are intended to reflect the current technology that's used in providing these services. And so the transition from film to digital imaging equipment and elimination of a separate coding for computer-aided detection services. And these changes will go into effect in 2017 through the use of new G codes. And CMS has decided that it will delay any changes to the valuation of the technical component for these services, and that it intends to make coding and payment changes for these types of services over a series of several years.
So are these rule changes moderate sedation or heavy sedation?
Oh, I think we could all use some sedation right about now. But with that, I will pass it off to my colleague Marguerite, who will talk about other aspects of the fee schedule.
All right, yeah, and I'm going to continue with some additional coding changes. So also in the final rules, CMS, they finalized a set of coding changes designed to improve the traditional fee-for-service payments to primary care and related practitioners, specifically for services to patients with multiple chronic conditions, mental and behavioral health issues, and cognitive impairment like dementia. These changes are what CMS describes as part of their ongoing effort to more accurately reflect actual resources involved in treating these patients and to get to the fact that what's being provided is ongoing care versus individual discrete services. So historically, care management and cognitive work was bundled into evaluation and management, or E&M visit codes, and CMS is now unbundling some codes and creating new codes in order to provide separate payment for these services. So just to note a few notable ones, they are now going to make separate payments for certain existing CPT codes that describe non-face-to-face prolonged E&M services. And so this is intended to provide payment for services that are provided either before or after the patient visit, but not necessarily on the same day of the visit. They provide just a couple examples, which include extensive medical record review or review of diagnostic test results and other care management work, and it has to be personally performed by the billing practitioner. And there are also some requirements on how long the practitioner is spending on the particular service for it to be billed. They're also making separate payments using new codes to primary care practices that are using interprofessional care management resources to treat patients with behavioral health conditions. Specifically, they're adding 3 new codes to describe services furnished using the psychiatric collaborative care model, which is one particular model that has been shown to improve quality of care. They're making several other changes to what they describe reduced administrative burden associated with chronic care management codes. They're making separate payment for complex care management services, including an add-on code for the initiating visit to increase overall payment. And then they've got a new code to describe the comprehensive assessment and care planning for patients with cognitive impairment. And all of these new codes are going to be implemented in 2017 via G codes.
So one of the, and I don't know, Marguerite, if you understood this better than I did. I did not, as I tried to read through this stuff. I've always thought, they talk about you need a face-to-face encounter for an E&M visit. I mean, like one of the old cases is a case involving a psychologist, Krizak, and the judge was annoyed because the government's position was if you made the same decision-making in the hallway as you did next to the patient, the government took the position it wasn't face-to-face. And, you know, Pari, you and I have worked on a long case where the whole denial was service incurred at the nurse's station, not in the room. And so I was really shocked to read this, and I don't know what fully to make of it. And I don't know if you have more, but I'm flummoxed a little.
I think that's fair. It's a lot of content that they added in there. The gist that I got was that it also had to be part of a companion E&M code that would involve a face-to-face visit. So they didn't specifically note that it doesn't have to be on the same day as that patient visit, which I think is an interesting differentiator.
So it has to be in the penumbra, like an orbit around.
Yes. They call it a companion E&M code that also has to be billed. And then the amount of time that you are attributing to that service has to be over an hour, I believe. So it can't just be a casual conversation about patient care. It has to be extensive review of care management.
Which 60 minutes seems like there are probably lots of patients that primary care providers provide extra services for or coordination for that take a lot of time but not necessarily 60 minutes. That seems too high to me, but
I think that's fair.
That's my opinion.
All right, moving on. The final rule also established the expansion of the Medicare Diabetes Prevention Program. So this is expanding a test model that came from the CMS Innovation Center, and it's making it available to then all eligible Medicare beneficiaries beginning January 1st of 2018. The program uses a group-based and classroom-style curriculum, which combines dietary coaching, lifestyle intervention, and some physical activity, with the goal being, as you might have guessed, to prevent the onset of diabetes in individuals who are pre-diabetic. The core benefit is a 12-month structured behavioral change intervention, which consists of 16 weekly core sessions in the first 6 months, followed by monthly maintenance sessions in the remaining 6 months. And in order to be eligible for the benefit, Medicare Part B beneficiaries have to meet a certain BMI threshold. They can't have a prior diagnosis of diabetes, and they also have to exhibit some pre-diabetic indicators. The final rule also outlines supplier eligibility, specifically getting at the fact that they want to enable providers who are already recognized as CDC diabetes prevention program providers enrolled in the program, and they're unlikely to already be enrolled in Medicare as of now. CMS says it's envisioning a payment structure that'll tie the payment to the number of sessions attended, and then also the achievement of maintenance, the achievement of some weight loss goals. But they haven't actually outlined any payment specifics or any other program details. They've hinted that they will allow the use of virtual providers, but all that is intended to come in 2017. Moving on, under the Protecting Access to Medicare Act, PAMA, of 2014, CMS was directed to establish a program to promote the use of appropriate use criteria, or AUC, for advanced diagnostic imaging services. So AUC are a library of individual evidence-based criteria to assist an ordering professional in making appropriate treatment decisions by factoring all of the specific clinical conditions of the patient. They link a specific clinical condition and then the multiple potential services, and then assess the appropriateness of the services. And the obvious ultimate goal is to allow the clinician to select the most appropriate imaging study for the particular patient. CMS describes the scope of the program in terms of the number of impacted clinicians as massive. And it's intended to apply to every physician or other practitioner who orders or furnishes applicable imaging services. So CMS started to shape the program in 2016 by defining the AUC development process and also defining provider-led entities, which are the organizations who are allowed to develop the specific AUCs. And then in this 2017 final rule, they established several additional components of the program by setting priority clinical areas for these AUCs, which I'll show on the next slide, and then also outlining the requirements for clinical decision support mechanisms, or CDSMs, which are the electronic tool that will link the AUC with the actual patient workflow and allow the ordering practitioner to access the data. The final rule also outlines several exceptions. One notable one is that they're finalizing an exception for ordering professionals who would face significant hardship in consulting the appropriate use criteria. They note, as an example, a rural ordering professional who would not have consistent internet access. They also say that if you are an ordering professional granted significant hardship under the Medicare EHR incentive program, that would carry over into this program, but the same is not true for the meaningful use significant hardship exception. All right, and here are the priority areas that they've established. They came up with these using claims data, coming up with some categories, and then they got fairly extensive feedback from the proposed rule and made some modifications. CMS also expects additions to this list to come in future rulemaking, but these are the areas that each of the clinical decision support mechanisms must have AUCs for all 8 priority areas. All right, and now just a quick final note on the physician fee schedule that Catherine hinted at and kind of stole my thunder, saying that there is no change. But so the final rule included a really lengthy discussion of unit-based compensation in rental arrangements for office space and equipment under Stark. So these are the so-called per-click arrangements. And obviously, I won't go into too much detail, but it was related to a 2015 opinion issued by the D.C. Circuit in Counsel for Urological Interest v. Burwell, which questioned CMS's interpretation regarding the legislative history that it relied on to prohibit these per-click arrangements, and then directed CMS to take a closer look. So CMS did just that. They took a closer look and decided to implement without any change the fact that these per-unit service formulas are prohibited for rental charges that reflect services provided to patients referred by the lessor to the lessee. So ultimately, no change. All right, moving away from the physician fee schedule, there was also a significant change. This was actually published back in June of this year for the clinical laboratory fee schedule. These are the so-called PAMA regulations, and they derive, again, from that Protecting Access to Medicare Act of 2014. The final rule requires all applicable laboratories, including physician office labs, to collect and report private payer data to CMS. A lab is subject to the reporting requirements if it has more than $12,500 in Medicare revenues, specifically from the clinical laboratory fee schedule, and it has to receive more than half of its overall Medicare revenues from a combination of the clinical laboratory fee schedule and the physician fee schedule. And both of those are calculated over a 6-month data collection period. There are some different rules for advanced diagnostic laboratory tests, which I won't cover today because it's a fairly limited category of tests. So just a quick note about the reporting entities. Oh, gotta switch the slide. The obligation to report is actually at the TIN level, but the determination of whether a lab is an applicable laboratory and then subject to reporting is determined at the NPI level, which has caused some confusion. This is a difference from the proposed rule, and it was done in order to capture hospital outreach labs, which would have their own unique NPIs. The original directive under PAMA was to implement new rates by January of 2017, but that thankfully is not happening. The initial reporting period is now the first 6 months of 2016, which labs must report to CMS by March 31st of 2017, and then CMS will post the new Medicare rates, which will be based on a weighted median of those private payer rates effective January 1st, 2018. So just a final note on what you actually have to report as an applicable lab. You have to report applicable information, which is the private payer rate for each test for which final payment has been made during the data collection period, the associated volume for each test, and the specific HCPCS code associated with the test. It does include Medicare Advantage plans and Medicaid managed care organizations, but it does not include any information for a test that is paid on a capitated basis. So just a note on those words, final payment. Final payment means the amount paid after all private payer price concessions are made. So that would include any discounts, rebates, coupons that affect that final price. The statute provides for civil monetary penalties of up to $10,000 per day for failure to report and for each misrepresentation or omission in reporting. And then payment reductions under PAMA were restricted so that the price for each particular test cannot drop more than 10% as compared to the previous year's payment for the first 3 years, and then 15% per year for the subsequent 3 years. And I will hand it over to Pari to cover IPPS.
So we're going to take a quick tour through some highlights from the inpatient prospective payment system rule, and I'm going to talk later about the outpatient prospective payment system rule. Of course, these are both lengthy rules like the fee schedule, and so these are not comprehensive sort of summaries by any means. First, on the IPPS rule. This rule has been out for a while. It was published back in August. I'm going to cover 3 quick topics from the rule: changes to the hospital readmissions reduction program, an update to the Medicare Outpatient Observation Notice called MOON. That's implementing the Notice Act, which came out back in 2015, and a very brief update to the Two-Midnight Rule litigation. I'll start with the Hospital Readmissions Reduction Program. This program's been around for a while. It went into effect back in 2012. CMS's goal here is to reduce hospital readmissions by reducing IPPS payments to hospitals that report excess readmissions. In order to determine whether a hospital will be subject to a reduction and to calculate the amount of the reduction, CMS requires hospitals to report data from a 3-year period. The rule this year provides that adjustments for fiscal 2017 will be based on data from July 1, 2012 to June 30, 2015. The program requires reductions based on the hospital's risk-adjusted readmission rates. And in the past, CMS has looked at readmissions related to certain conditions, so acute MIs, heart failure, pneumonia, COPD, and certain hip and knee replacements. For fiscal 2017, CMS is making 2 changes to these condition measures. First, they're refining the pneumonia measure, and second, they're adding a new measure for readmissions related to coronary artery bypass grafts. CMS seems to expect hospitals to do worse on these measures than they have in the past because they expect to save Medicare, i.e. reduce payments to hospitals, by $528 million in fiscal 2017, which is $108 million more than the reductions were worth to the Medicare program in 2016. CMS also reaffirmed its public reporting policy in the commentary to this rule. Excess readmission rates and data and the reported data will now be posted to the Hospital Compare website. CMS has already started putting this data out there. The first set of annual data went up on the website in October of 2016. CMS tells us in the commentary to the rule that it intends to annually post data, although perhaps earlier in the year if it's feasible to do so. We also have a little update on the MOON. This is the Medicare Outpatient Observation Notice. As you recall, the Notice Act requires hospitals, including critical access hospitals, to provide written notification and oral explanation to individuals receiving observation services as outpatients for more than 24 hours. The concern here is that patients won't be sufficiently advised of how their outpatient status would affect their later SNF eligibility or their co-payment and cost-sharing obligations. The IPPS rule provided that the MOON must be given to patients receiving observation services as outpatients for more than 24 hours, no later than 36 hours after the observation services are initiated. It might even have to be earlier if the patient is transferred or discharged or admitted as an inpatient before you hit that 36-hour mark. So the notice has to be signed by the patient or the patient's representative, and you have to provide a verbal explanation with it. You'll notice that 24 to 36 hours is only a 12-hour window, which is not so much fun for hospitals to actually implement. So the rule says you can provide it earlier than 24 hours if you want to, but CMS does not want you to provide it too early. For example, they don't want you to give it at the initiation of observation services because they think that it'll get lost in all the paperwork that's given to people at that time. The real update here is that CMS provided in the IPPS rule that the MOON rule wouldn't be enforced until 90 days after CMS released the form, the actual MOON form. CMS anticipated the notice would be released on October 1, 2016. It was only 2 months late, and it was actually released in final form last week on December 8th, meaning the rule will start to be enforced beginning March 8th of next year. Here's the form. It's obviously gorgeous, and they've gotten it down to a pretty manageable 2 pages. It's available on the CMS website, or we can shoot you a link to it if you need it.
And I suppose we should just chime in here, too. In one of the challenges we've got with our webinar you know, there's also potentially a state law thing. So we're sitting here in Minnesota. Minnesota has a, I'm about to say conflicting, but at least non-perfectly harmonious requirement. We are lucky enough or cursed enough, depending on your perspective, to have, like, I think 48 states represented on the webinar today. You know, I know we've got people from Hawaii and Alaska and Florida and Maine. You know, we've got the, and so we can't go through all of the state law provisions. And the truth is, we know some of them, but we don't know all of them. And so it's just a good time to remember we are talking federal here. It is always good to pay attention to your state stuff and to recognize, you know, you could have inconsistent requirements. We tried really hard to get the state of Minnesota to say, hey, let's be consistent with the federal law. But the Department of Health, someone understandably said, look, our hands are tied. The law is the law, and their laws are inconsistent. Sorry about that. And like, so just as an aside, the Minnesota one, you have to give it to all patients, not just Medicare, even though we're talking about a Medicare law. So the world isn't always rational. So Pari, what else we got on our midnight? It feels like it's midnight, you know.
Yeah. So if you are someone who is genuinely interested in administrative law, you may remember this. If you are not, then you probably only remember it because it resulted in a rate cut. So the 2 midnight rule was linked with a reduction in the IPPS rates on the counterintuitive theory that this rule would actually create more inpatient encounters. That doesn't make sense because the rule before was that a person is treated as an inpatient if they're there for more than 24 hours. And the 2 midnight
or overnight.
Or overnight. And the 2 midnight rule says you have to be there for 2 midnights, which could be longer depending on when you start, right? So the agency concluding this is going to increase inpatient encounters and therefore increase costs, requiring a cut to offset didn't make a ton of sense. Hospitals noticed this and they sued because the agency's reasoning seemed weak and they didn't provide a lot of details. This is like an administrative law thing where the agency has to explain itself. So there was a procedural challenge to the rule. The District of D.C. ended up remanding back to the agency for a more robust explanation of how they came up with this, but they left the rule intact. In the IPPS rule this year, after CMS solicited additional comments about all of this, they maintain that the actuarial assumptions supporting the cut were reasonable at the time that they were made, but they were wrong. So now they're going to reverse the 3 years of cut of 0.2% cuts with a one-time 0.6% increase for fiscal 2017. So I guess administrative law sometimes results in you getting money.
Yeah,
would be the lesson here.
This is the, I'm sorry I wasn't wrong, but I'm going to do what you asked me to do anyway. We're not admitting liability. We're just paying you.
Right, a technique perfected by my brother in elementary school. So we're going to hop over to the OPPS rule. This one's a little bit more recent. It came out in the Federal Register on the 14th of last month. We're going to take a quick pass through updates to the hospital outpatient quality reporting program and to some changes to the EHR incentive program. And then I'm going to pass it over to Katie, who's going to talk about all of the things that are happening with provider-based outpatient hospital departments. So I just have a quick note about the hospital outpatient quality reporting program. CMS is adding a handful of new measures, including measures that sort of all get bundled into the outpatient ambulatory surgery CAPS measure. CMS is revising those measures to remove questions about pain management due to concerns about opioid overprescribing. So it looks a little different than that measure's looked in the past. And CMS is formalizing what is apparently its current practice of publishing these quality measures on the internet. There'll be a 30-day preview period, but your data on this stuff will be out there. Finally, we're going to talk a little bit about updates to the EHR incentive program. As I'm sure many of you are acutely aware, this program is on the way out, and MIPS, which Katie's going to talk about, Katie and David, is on the way in. And that transition will be complete at the end of 2018. CMS is making some changes to this program for its last 2 years. I'm going to take these actually out of order. We're going to talk about the last one first. First, CMS is finalizing the 2016 and 17 reporting periods for returning participants. It needs to be 90 continuous days during the relevant year. It's not particularly exciting, but there it is. Second, for eligible hospitals and critical access hospitals attesting meaningful use in 2017 and 18, CMS is eliminating some of the measures related to, well, eliminating entirely the clinical decision support and computerized provider entry objectives and measures. This does not apply to attestations made to states for state Medicaid EHR incentive programs, since those are conducted under different statutory authority. CMS is also lowering thresholds on many of the other meaningful use measures, generally to the stage 2 levels. CMS also announced that it has put together a significant hardship exception to the 2018 payment reduction. The exception is only available to a pretty narrow slice of entities or individuals. It's just eligible providers who have not significantly demonstrated meaningful use in a prior year, but who intend to attest meaningful use for 2017, relatively early in the year, and they intend to transition to MIPS and report on measures specified for the Advancing Care Information Performance category for 2017. As they've been in the past, the hardship categories are pretty limited. The EP would have to demonstrate that she's got infrastructure barriers, like they're in a rural area that doesn't have access to the internet, that there are extreme and uncontrollable circumstances like a natural disaster, that the EEP is practicing in multiple locations and doesn't control the EHR system, or for certain specialists that they can, if they need to be able to show they lack face-to-face or telemedicine interaction with patients, or lack follow-up need for patients, such that having an EHR system doesn't make a lot of sense for them on a patient-facing or continuing care sort of perspective. The application is up on CMS's website now for anyone who may be interested in applying, though, again, the threshold requirements are pretty narrow. I think that's it. I'm going to toss this back over to Katie to talk about provider-based.
Okay. I am being passed the slide clicker. I have the slide clicker. Okay. So most of you probably know in 2015, Congress said, at CMS's urging, we are tired of paying for services at outpatient, off-campus outpatient provider-based departments than if those same services are provided at a freestanding clinic. They were equating these two sites. So we are going to stop paying more for certain services on the off-campus provider-based departments. And that is going to happen starting January 1st. Starting January 1st, there will be no outpatient prospective payment system payments for any new, quote, new off-campus provider-based departments. Instead, those services will be paid under the Medicare physician fee schedule. There will be site-neutral payments. There will not be a difference in payments between off-campus provider-based and freestanding departments. So what in the world, how do you know if you are getting site-neutral payments or if you still get paid under the OPPS? You will continue to get paid under the OPPS as an off-campus provider-based location if you were providing services and items at that location prior to November 2nd, 2015. Anything that was any department that came into existence and was reported to Medicare on their enrollment form after November 2nd, 2015 will have site-neutral payments. You won't get paid under the OPPS. So there were a couple things that were up in the air in the proposed rule, and probably the biggest uproar was CMS's statement that it will not be paying hospitals for non-accepted items and services. So it won't actually pay hospitals for those services in the off-campus locations. Instead, the hospitals were supposed to figure out how to have, I guess, physicians bill for those services and then get the money back from the physicians. So hospitals were saying, we don't bill to the fee schedule under with our UB institutional claim forms, how are we supposed to do this? And CMS said, you guys figure it out amongst yourselves. And that was just unacceptable. So beginning January 1, Medicare will pay under the fee schedule to hospitals for these non-accepted items and services. You can bill on an institutional claim form, and you are supposed to use this PN modifier. So that was resolved. That was probably the weirdest part of the proposed rule.
Yeah, well, the other thing that got a lot of play was there was a proposal to not allow you to do new items or services. And I mention this only because I saw more than one consultant say, this is in the proposed rule, don't provide any new services. And I think that there's just a really important lesson in here, which is proposed rules, you got to emphasize that proposed part, because there was a hue and cry about that proposed rule as well. There should have been. And one of the big questions is, what the heck is a new service? You know, I mean, so there was a question, could you start providing oncology, if you weren't, or something like that? And that part of the proposed rule wasn't adopted, so it's gone. But jeepers, a bunch of people were making we're telling you to act on the proposed rule, and don't.
So you took the words right out of my mouth, David. In fact,
Meatloaf?
the proposed rule had this weird way of describing what were new services, and they had different clinical, groups, making everyone think that they weren't going to be able to add service lines. In fact, if you have an accepted location, so you had your provider-based location as of November 2nd, 2015, you can indeed add more services there. CMS did say they were going to look at kind of this expansion and how much there is and if they want to further limit it. So that's, at least for now, feel free to add service lines. What you have to be very careful of right now is moving your physical location. So as of November 2nd, 2015, you're locked into the address and the suite number that you had reported on your enrollment application. So don't willy-nilly go rearranging things, even within the same building, because you will run into cut in payments.
And that one's an easy track. I mean,
it's easy track. You could easily see someone on the sort of the planning side of things moving services around and not checking.
So this
with
is
the
a
reimbursement side.
Send a memo to your facilities people saying, hey, don't rejigger your outpatient department stuff. So
the other
and that's my mistake. Off campus only, right?
Off campus.
Okay.
So the other the other interesting thing to think about when you're doing transactions is that you're going to lose your accepted status. You're going to lose your grandfather status if you sell the off-campus provider-based location, unless the buyer both assumes the main provider agreement as well as the accepted location. And as many of you know, in a lot of these transactions, the buyers don't necessarily want to assume a provider agreement because that comes with it all the liabilities underneath that provider agreement. So think about this as your transactional planning piece as well.
And I may have zoned out, but how big is what's the definition of a campus?
A campus is 250 yards from the main building. So that's a whole webinar that, in fact, we did in
really
April.
is, yes.
And if you're...
It's a really good webinar, by the way. It's April 2016.
If you're struggling with what are you on campus or off campus, let us know, because there are some interesting arguments there. It's not a bright line 250-yard rule. There's some discretion. So happy to chat with you about that.
Katie Breyer and Steve Beck did that webinar, and I learned a lot from it.
I learned a lot as well.
We try. So switching gears. So let's talk about MIPS, and really the right question is, what is the quality payment program? So the quality payment program is the new way that CMS is going to go about trying to pay people based on quality, increasingly based on quality instead of just fee for service.
Actually, Katie, I think the real question is, what is MIPS? Because it's the Medicare Incentive Payment System, right? Because I get that wrong every time.
Yeah.
So I always think it's the Medicare Incentive Payment System. But am I right?
It's actually the merit-based incentive payment system, and based is not part of the acronym. So don't get that.
So I'm never going to give up on me. But okay.
So this the idea is to consolidate all these various reporting programs that you are all very aware of, PQRS, value-based payment modifier, and EHR program. Pari is smarter than me in figuring out how the EHR program continues to exist while being phased into MIPS, and she talked about that, and if you have questions about that, please ask her because she has that down. So the quality payment program, that's the umbrella for the two, I guess, pillars of how you do quality payment going forward. So the first way you can participate is through an advanced alternative payment model. And anyone who's participating in one of those, which I'll go through, is going to see their incentives or negative adjustments through those models. And those folks will not have to worry about participating through MIPS. MIPS is the other side of it, and there are 4 components, which I've put here: quality, clinical practice improvement, resource use or cost, and then meaningful use of EHR. Those 4 components are going to have weighted, you're going to report on eventually all 4 of them, and your reporting and your data will be weighted. Each one will have a different weight. Those weights, as in WEIGHT, those weights will change over the years. Dave is going to talk about what those weights are in the first year, but ultimately those 4 components, as weighted accordingly, you'll come up with a composite score that will determine where you are in terms of a negative payment adjustment, nothing happening to you, or a positive payment adjustment. So the first year that you'll see reporting is 2017, and the reporting in 2017 will affect Medicare payments that come to you in 2019. So who participates? So on the MIPS side of things, you will know if you're, hopefully you will know if you're participating in an advanced alternative payment method. I'm going to get my acronyms wrong. But who participates in the MIPS side of things? So for the first 2 years of the program, the regulations have said that MIPS eligible clinicians are these types of clinicians: physicians, which actually refers to the statute. So that's the expanded definition of physician, which would include dentists, podiatrists, optometrists, and chiropractors, as well as MDs and DOs. Physician assistants, nurse practitioners, clinical nurse specialists, and then CRNAs. Those are the MIPS eligible clinicians for years 1 and 2. In years 3 and on, there will be more rulemaking, and we have very good reason to think that CMS is going to expand clinicians, eligible clinicians, to audiologists, speech language pathologists, physical therapists, occupational therapists. So if you're one of those types for years 1 and 2, then you're eligible. Also, you have to bill more than $30,000 a year to Medicare Part B and see more than 100 Medicare patients. So, in other words, skipping to the second bullet, clinicians who are low volume clinicians are not going to be part of MIPS. If you are newly enrolled in Medicare for the first time, not as part of a new group, but you are a new Medicare enrollee during a performance year, then you will not be required to participate in MIPS for that performance year. And then, obviously, if you're participating in an advanced APM, then you won't be doing MIPS.
And actually, correct me if I'm wrong, Kate, but I think it's even weirder. It's not that you won't be allowed to, or required to. I think you can't, I believe.
Yeah, I think that's actually right, because I know you can report if you're not an eligible clinician, if you're a different type of clinician, like an audiologist can report, but I don't know if you even can report if you're newly enrolled.
I believe the answer is no. I mean, this stuff is...
so that's lucky for you guys. So we put this a couple different ways in the slides because people learn differently. This is how my brain works. There are 4 ways to participate in the quality payment program for the first year. You can be an advanced APM, or you can do MIPS 3 different ways. The first way would be what you need to do at the very minimum to not see any negative payment adjustment, and you wouldn't get a positive adjustment. You would report on only one measure in each of the 3 categories because cost is excluded, so only 3 the first payment year. So you only port 1 in each of the 3 categories, and if you do that, you're not going to see a downward adjustment in 2019. You could also try a little bit harder and do 1 measure in all 3 plus at least 1 more additional measure in at least one of the categories for the reporting period, which is 90 days or a full year, and you would not get the negative adjustment, and you might get a positive adjustment. And then you could do the full-blown overachiever route, which is you report on all of the required measures for each category for either the 90-day or the full year period, and you're safe from the negative adjustment, and then you could get up to the max positive adjustment.
And there are a bunch of things. I mean, I think this MIPS stuff is pretty confusing in a bunch of ways. One is, this is not a requirement. We're not talking about something you have to do. We're talking about something that if you don't do, you take a payment whack. So it kind of feels like a requirement, but it's an option. It's a choice. You can choose to do whatever, and we'll talk in a moment about what the economic consequences of your choice. And frankly, you might have to do some math, because it's going to matter. You're going to have to think about how many Medicare patients you have and how the financial haircuts we'll talk about in a few slides will affect you.
So the advanced APMs, I've just kind of listed them for you. There's not, the MIPS, the Quality Payment Program does not change any of the advanced APMs as they are. They are as they are as CMS set them up. It's just folding it into the Quality Payment Program so that if you go that route to participate, you would just follow those rules and see what other upside or downside you get under those rules. So, at least for 2017, these are the advanced APMs that would count for the Quality Payment Program. In future years, the MACRA legislation set up a committee to look at some new payment models.
And this is a big deal, because I think what doesn't count, I think, is stunning. I think people were thinking CJR would count.
Right, for next year.
When the cardiac bundling programs comes out, it would count, and it doesn't.
So we do think that we will see next year at this time if they've set up CJR to count for an advanced APM, but I think after 2017 we can probably expect that. Check back next year in this webinar. But these are the ones at least listed here that CMS has said, we think they'll be there.
And just because I think this is at least unclear to me at times, but if you're in an APM, basically you don't face the whack that you can get under MIPS. So let's talk about how that whack works.
But you might have a downside risk in the
APM. Yes. So and that's kind of what it is that the APM downside risk replaces the whack.
Right.
So there is still a potential whack. It's just a different whack. Mm-hmm. So the weights for 2017, and this is real. It's hard to explain this because when we say it's the weights for 2017, you get measured in 2017 again for payments that you will get in 2019. And basically there's a 2-year lag that's constantly built into the system. So in 2018 you'll get measured for stuff that you will affect your payment in 2020. So just think 2 years out. So the weights for 2017/2019, there's a quality component that's 60%, various improvement activities. So and quality is, if you think PQRS, and we pulled this slide right out of CMS. It's kind of helpful, although the numbers we sort of tossed in. But think what used to be PQRS is now called quality, and 60% of the money is going to come there. Improvement activities, which are really new, are 15%. Advancing care information, which is really what you used to think of as the meaningful use program, are 25%. And then cost isn't in yet, but it will be. And basically that's going to be grading you on a curve. The plan is they'll grade you on a curve. And if you compare unfavorably with peers, you'll get a whack. If you compare favorably, you'll get points. And so then this all kind of goes into a points hopper. So what are we talking about? This is really a bonus penalty with a 4%. The up and down swings are the same, but put an asterisk there. We'll come back to that in a moment. So it starts out at 4% in the payments in 2019. So your 2017 measures, 4% impact on 2019. What you do in 2018 will have a potential 5% up or down impact in 2020, and then you just go out each year. 2019, 7% impact for 2021, and then it caps out at 9% and stays there. So what was the asterisk I'm talking about? This has to be budget neutral. This program can't increase or decrease the amount of money that Medicare is going to pay. All it can do is, so the pie size doesn't change, the slices of pie are going to change. So CMS expects that there will be more losers than winners. And if that is the case, the winners can get more than the upside that's here. And in fact, they're allowing up to a triple upside. So it is possible that in 2022, a winner won't be talking 9%, they'll be talking 27%. No guarantees there, and it's kind of contingent on how poorly everyone does, which is one of the things that this makes this, doing the math, you said you have to kind of do some calculations to figure out what you're doing. You could look and say, all right, how much Medicare do I have? Can I afford to lose? And then you might say 4% of my Medicare reimbursement. That's kind of a bad way to look at it, because 3 years out, you're talking 9%. And so unless you've got a plan to retire in the next 2 or 3 years, you really got to, I think 9% is your math. Now, this is tough. So we have struggled with how much to dive into this, because, I think we tend to be straight shooters. I am not sure how much people are going to use lawyers on this stuff. I kind of think they should. I mean, what we've learned through CJR is that people don't read the fine print. And so when I say to people, you know that hospice care is part of the CJR cost calculations, they look at me like I'm from the moon, to harken back to Pari's moon conversation or my rocket launch conversation from before. So they look at me like I'm from the moon. But it's in there, and it's just that no one reads it. I have read through a chunk of this stuff. I know, Katie, you've read through a chunk of this stuff. It's hard, and it's hard to stick with, and I honestly am not sure how much time to spend on it, because I don't know if you folks are going to be calling us a lot on this stuff. And it's hard. You aren't going to want to, this is going to be, there will be consultants who spend a lot of time learning this stuff, and it's going to be tough. But here's kind of how it works at the 30,000-foot level. So first you've got these quality measures, and there's a big list in the Federal Register. I put the page at the beginning of like 100 pages. There are a boatload. It's almost 300 measures to choose from. And now you can't, I suppose you can choose any one, but many of them won't be applicable to you, right? If you're an endocrinologist, this asthma control may not be for you, right? It's very specialty specific. So to fully participate next year, you either do 6 individual measures or 1 specialty or subspecialty set, and then you're in potentially for the full upside. As a special deal in 2017, you can do the minimum, and the minimum basically means you do it for the last 3 months. So you start September 1st, and it has to be in effect by September 1st. So you get a lot of ramp-up time.
But maybe don't start exactly September 1st, because if you have a glitch.
And that's an excellent point, Katie. Yeah,
problem.
right. That's a really good point. If you lose a day, you're toast.
I would start in July.
So, and Katie is always more organized than me and wiser. And so start early, so if you screw it up, you're all right. But you get a run into the middle of the year. If you just do 1, you're okay. And then there's one part, and I actually don't fully understand this. If you use the CMS web interface, you have to do more, and I didn't fully understand that nuance. And so I toss it out there and then stare blankly at my own. I give the talk and then stare blankly. But here's kind of how the quality measures look like in the Federal Register, and so you can thumb through and figure out which ones are appropriate for your specialty. So resource use, think cost, doesn't matter this year, so we won't spend long on it, but basically they're going to convert it to points and then grade you on a curve, all right?
And we think it will be a significant part eventually.
Yeah,
cost will be very important.
In fact, kind of what they're saying is the EHR part, they figure EHRs are becoming the norm. That's going to go away. It's there now. It matters, but that will fade, and this cost thing's going to matter. And so improvement activities, and these are things like care coordination, shared decision making. It's kind of counterintuitive. Emergency preparedness. So there's stuff you go through with. But getting your beneficiaries to get married. I think that's what beneficiary engagement is, isn't it? I'm assuming that
of course.
Must be.
Must be.
So if you're going whole hog, you have to do 4 improvement activities from your 90 choices. Yeah, and to not get your cut, you have to do at least 1. And then the meaningful use, which starts off at 25%, and as Katie is pointing out, is going to decrease. That's got full measures. You have to do 5, a minimum of 1. And that's really the gist of it. And so, here's kind of this graphically saying what we've been saying. You work during 2017, you report by March 31st of 2018, get data back, and then you take the whack starting January, or get the bonus. Boy, that was really negative of me in 2019. I don't like this. We've left this one in part so we could criticize it, because I don't like the partial and full at the end, because it's misleading. Because for full, it talks about how if you do a full year, you may earn a positive payment adjustment, but it skips mentioning how you may be neutral. For partial there, if you can read the fine print, it says you can either be neutral or get positive, and that same is true for full. There's no guarantee you get money out of this. So they trap you, and it looks and that tank looks very full. All right, we're going to close with the OIG work plan.
I would say one more thing on quality payment.
Please do. Yes.
So I was initially very taken by the CMS website on quality payment because it looked nice and it was a lot more user-friendly than the PQRS and EHR websites that they had. But that graphic that David just criticized, and then I think that the quality payment website that they have is good as a starting point, but don't rely on it fully because it doesn't get into the nuance that will ultimately make you sink.
And this is the same point we're kind of getting at. I'm scared people won't pay attention to the details here, because when I look at this stuff, it's hard, it's boring, and the details matter. And so you're going to need someone to dig into the details. This sadly is going to be a full-time job for people. And personally, I wouldn't want that full-time job. But I don't know if people are going to use their lawyers for this, but what Katie's saying about how the web's simple here, in order to make it simple, it almost by definition isn't entirely accurate. All right, the OIG work plan. Not a boatload of stuff going in. We'll just do this in about 5 minutes. We have a few questions, and we'll end probably a little bit early. What do you use the OIG work plan for? Well, here's how I use. First, I'll tell you, if you ever want to know what acronyms are, there's a nice little table in there, and it's useful. And it gives you a sense as to what they're looking at. So actually, people, I think, sometimes misunderstand some of what it's talking about in there are upcoming reports. So it tells you what reports the OIG is working on. One of the things, I have been lucky enough to give speeches about the OIG work plan for a number of years, which causes me to actually read it in detail. And then you notice it's a lot like watching, I don't know what the seasons are anymore. And when I was a kid, it would be like watching television in the summer, which was a rerun season. And I think that has gone away, and I'm old and dating myself. But what this year's OIG work plan looks a lot like last year's OIG work plan. And in fact, what's really interesting is reports that were going to come out in calendar year 2016 are now just like the 16 is crossed out, and it just says 2017. And some of those will cross out and say 2018. So sometimes it says the report is out. Sometimes it says we're extending it. There are a few new areas that they're going to talk about. Hyperbaric oxygen therapy services. Katie and I have been talking a lot. We've got, I think, 3 hyperbaric oxygen things in the office right now, something like that. It's one of those things I didn't know much about what was going on, and now I'm busy with it.
The OIG doesn't like it.
The OIG does not, or at least there's a lot coming up. There's provider-based issues. There's reimbursement issues, bunch of stuff. They're looking at incorrect medical assistance stays that are claimed by hospitals, inpatient psychiatric outlier payments, then IRF. IRF has been a hot issue. It often comes down to what people call misleadingly the 3-hour rule. And I guess I call it misleading because people often think that you have to provide 3 hours of therapy to a patient. And in fact, that's not what the rule is, because some people sometimes then think if you provided 2 hours and 57 minutes of therapy, you're screwed. And the actual rule is that the patient has to be able to withstand 3 hours of therapy. And if you're a minute off here and there, that shouldn't sink you. But that basic principle within IRFs has been a source. I know we've had a couple of audits on that. And if you need an IRF consultant, by the way, I know a couple of really good ones. Hospice, clinical diagnostic lab, and then a topic that has come up for quite a while, drug wastage of single-use vials, which I apparently am not going to be able to say very easily. And that's the basic idea. You know, you've got a single-use vial. You can only bill for using it once. Like if you use a single vial for multiple people, you can't bill the same vial 3 times. That would be violence against the system.
Oh, stop, David.
Okay.
It's better than usual.
So then there are a few new areas: transition care management, chronic care management, and then one of my favorite, services after patient death. And no, that is not about a eulogy, although it sounds that way. Apparently, the government thinks that you're not supposed to bill for services to people after they're dead.
Shocking.
It really is. Now, to be fair,
Wait, for services provided to them before they died?
no,
Okay,
that would
all
be
right,
maybe
right.
okay.
That's okay.
It's the after they died part, I think, is the problem.
Yes.
So that's and what so frankly, one of the things that goes on here, actually, you and I were just talking about one of these. Someone who was really sloppy. They saw the person last week, right? It might have been Monday, might have been Wednesday, maybe it was Friday. We'll just bill it, and you bill it on Friday, and it turns out the person and maybe you really did the service on Monday, but they died on Tuesday, and it turns out the government doesn't look favorably.
And we've seen a couple of these issues.
Yeah.
A couple it's data mining, obviously, and the data mining abilities are getting much better.
It's easy. That's an easier
it's
one.
An easy
to
one
find.
to mine. Yeah.
And then there are the oldies but goodies. I do lots of my 60s music and stuff. More 80s. I'm really more an 80s guy. So outlier payments continue to be big. Replaced medical devices. So this is something I didn't know about until I learned it when the OIG came out with a report looking at a big, well-known institution and whether they were giving proper credits. If a device fails and you replace it, there is a fairly complicated policy on how you handle it, especially if you get more than a 50% credit. And that has been in the OIG work plan for a number of years. You know, Katie was talking about how much they hate provider-based stuff compared to freestanding, and they love to criticize. There's a recent episode out west, is in Montana, where the government does not like shared space in a provider-based context. Yep. And Katie knows a boatload about that. Breyer, I know a little. That's been an interesting fight. The 2 midnight rule, and then I left up, and I feel a little I just left it up because it's hard to say, and then I feel like I'm being a little too flip. But patients with I can't even say it, but it's a rare disease, and it has been in the OIG work plan at least 3 and maybe 4 years in a row. I know we got a couple of questions. Some of them are very specific, and we won't do those. But what do we got? We have any? Do we have any questions?
We have some state law questions. We'll answer those on a one-off.
Yeah, and just maybe we don't have anything we're gonna dive into right now?
One person wanted to clarify, and I think I said this really quickly, so I'll say it again. MIPS eligible clinicians, those who aren't eligible right now, but who may be in 2019, like audiologists, may voluntarily report. That's allowed, and you can do that, and maybe that would be good practice.
And I know there was one about, does CMS understand how big a pain in the butt this is? And I would say no. On that, I think they don't.
But I think they brought up a good point. So that was about the lab tests, if we're referring to the same question. And so they bring up a good clarification, which is that CMS has said if the lab has more than one payment rate for the same private payer for the same test, or more than one payment rate for different payers for the same test, the reporting entity has to report each such payment rate and the volume for the test at each individual rate, which means you have to break down this lab data into fairly granular information.
Thanks, Marguerite. That's helpful and confusing.
Sorry.
Well, not you. You aren't, but it's helpful and burdensome. Maybe would be a better way of putting it. All right. Well,
if you have ideas for topics. We really, really want to hear them.
Yes. We think immigration will be in January. We're not sure. We also, I sense a grab bag in our future. It's such a popular topic. But yeah, we would like to hear things. You will get an evaluation form, and just throw topics. We do read these things. Believe me, it gives the people a chance to mock me. That's always welcome. All right. Thank you guys so much. Have a happy whatever holidays you celebrate, and a great new year. And check out the moon tomorrow morning. I'm going to assume it's going to be as pretty as it was this morning, at least if it's clear where you are. Thanks all.
Take care.